Title: Hypokalemia by Dr. Saijo. Clinical scenario: a 52-year-old woman presents to the emergency department with progressive muscle weakness, palpitations, and generalized fatigue for the past 3 days. She has a known history of hypertension and has been taking hydrochlorothiazide for the past 2 years. She also reports vomiting for 2 days following suspected food poisoning. She has no history of diarrhea, no use of herbal medications, and does not take laxatives. She now complains of muscle cramps, difficulty climbing stairs, and occasional palpitations. Today, we will discuss hypokalemia under the following headings: definition, causes, clinical features, and management. Definition: hypokalemia refers to a decrease in the serum potassium concentration to below 3.5 millimoles per liter. Potassium is a vital electrolyte that plays a key role in maintaining normal muscle function, nerve conduction, and cardiac electrical activity. Because potassium is primarily an intracellular ion, even minor reductions in serum potassium can lead to significant physiological effects. Severity. Classification 1. Mild hypokalemia, 3.0 to 3.4 millimoles per liter. Often asymptomatic, may present with mild fatigue or muscle cramps. ECG may be normal or show subtle changes, usually corrected with oral potassium supplementation. 2. Moderate hypokalemia, 2.5 to 2.9 millimoles per liter. Muscle weakness, constipation, or palpitations. ECG changes such as flattened T waves or U waves requires urgent correction. May need intravenous potassium 3. Severe hypokalemia, 2.5 millimoles per liter. Severe muscle weakness or paralysis. Risk of life-threatening arrhythmias such as ventricular tachycardia or ventricular fibrillation. Prominent ECG abnormalities requires immediate IV potassium with continuous cardiac monitoring, often associated with concurrent magnesium deficiency, causes renal losses, diuretic therapy, especially loop and thiazide diuretics, hyperaldosteronism, renal tubular acidosis, magnesium deficiency, excess licorice ingestion, non-renal losses and other causes, gastrointestinal losses, vomiting, diarrhea, nasogastric suction, poor dietary intake, insulin therapy, beta agonists, alkalosis causing intracellular potassium shift. Clinical features: muscle weakness and cramps, fatigue, constipation, or paralytic ileus paresthesias. In severe cases, paralysis, respiratory muscle weakness, or rhabdomyolysis. ECG changes include flattened T waves, prominent U waves, ST segment depression, prolonged PR interval, arrhythmias such as premature ventricular contractions, ventricular tachycardia, or ventricular fibrillation. Investigations: serum electrolytes, potassium, magnesium, sodium, acid-base status, urinary potassium, to differentiate renal from non-renal losses, ECG, renal function tests. Management of hypokalemia 1. Treat the underlying cause, adjust or discontinue diuretics, manage vomiting or diarrhea. Treat hyperaldosteronism. Review medications that shift potassium intracellularly, such as insulin or beta agonists. 2. Management of mild hypokalemia. Oral potassium chloride, 40 to 100 milliequivalents per day in divided doses. Encourage potassium-rich foods such as bananas, oranges, potatoes, and leafy greens. Monitor serum potassium over 24 to 48 hours. 3. Management of moderate to severe hypokalemia. A. Intravenous potassium. Indicated for potassium levels below 2.5 millimoles per liter. Significant symptoms or arrhythmias, inability to tolerate oral intake. Dosing: 10 to 20 milliequivalents per hour via a peripheral line. Up to 40 milliequivalents per hour via a central line in critical cases, always with continuous cardiac monitoring. Recheck potassium every 1 to 2 hours. B. Combine oral and IV potassium, used in stable patients with significant deficits. 4. Correct magnesium deficiency. Magnesium deficiency is common in hypokalemia and prevents proper correction. Administer intravenous magnesium sulfate, usually 1 to 2 grams over 1 hour. Correcting magnesium reduces renal potassium wasting. 5. Stop offending drugs. Discontinue or reduce diuretics. Stop laxative abuse. Reduce beta-agonist doses. Consider potassium-sparing agents such as spironolactone, eplerenone, or amiloride 6. Monitoring continuous ECG monitoring for moderate to severe hypokalemia. Regular checks of serum potassium, magnesium, bicarbonate, and renal function. Watch for signs of overcorrection, especially hyperkalemia 7. Dietary advice and prevention. Encourage potassium-rich diets. Routine electrolyte checks for patients on chronic diuretics. Use potassium-sparing diuretics when appropriate. Potassium deficit calculation. A common formula for estimating potassium deficit is normal lower limit, measured potassium, x weight, kg, x 0.4. Example, measured potassium, 1.9 millimoles per liter, weight, 23 kilograms, calculation, 3.5 minus 1.9, times 23 times 0.4 equals 14.72 millimoles. Add daily maintenance of 1 millimole per kilogram. 23 millimoles plus 14.72 millimoles equals 37.72 millimoles. This amount can be divided and added into IV fluids, provided the patient is making adequate urine and does not exceed recommended daily limits. Potassium chloride ampules vary, so checking the labeled millimole concentration or using simple mole calculations is essential. This will be covered in a separate video. Conclusion: complications and prevention. Hypokalemia can lead to dangerous complications such as paralysis, arrhythmias, and respiratory failure. Early recognition, appropriate supplementation, correction of magnesium, and addressing underlying causes are essential for prevention and effective management.